introductions. If we could go around, I'll state the entity, and either the health department or others. We're really happy to be joined today by the CDC Data to Care team as well. So if you could please state your name and role within your organization, that would be great. So let's start with the health department, and we'll start with the Colorado Health Department.
This is Jennifer Donnelly, and I'm in the room with a few others, Rosemary Nelson, Sue Prozequis, and Maria Chaidez, who are all part of the Data to Care, Linkage to Care group, and HIV prevention.
Great. And do you have surveillance represented as well, Jennifer?
Not yet, but this coincided and kind of overlapped slightly with our division meeting, so they should be here shortly.
Great. Okay, thank you. And from the Virginia Health Department.
Hi, Brian Collins. Can you guys hear me?
Great. Yeah, Brian, you sound clear. Thanks.
And this is Beth Sofovich. I'm also with the Virginia Health Department.
Okay. And Brian and Beth, could you just describe what your roles are briefly, or your positions?
Sure. I'm the CAPAS coordinator for Virginia.
Great.
And I'm the HIV prevention evaluation coordinator.
Great. Thanks. Okay, South Carolina Health Department.
This is Eric Jalone, and I'm the surveillance coordinator.
Great. Hi, Eric.
Hi, this is Monitha, Linkage to Care Program Coordinator and the point of contact for the Data to Care with JSI. And in the room with me, I have Tony Price, who's the Program Manager, Keisha Hightower, who's our Contracts Monitor, and Jennifer Turner, who's our Evaluator.
Great. Thanks, Monitha, Eric. Other health departments who may have joined the webinar today, could they please introduce themselves?
Hi, this is Betsy from Massachusetts. I'm the HIV and STD Surveillance Director, and I'm here with Christian Haig, who's the HIV Surveillance Supervisor.
Great. Thank you for joining, Betsy and Christian.
And this
Any
is Becky
others?
Grigg in Florida. I'm the HIV/AIDS Surveillance Coordinator.
Great. Thank you. Any other health departments? Okay. Did anyone else want to introduce themselves who may have joined after we started, and then we'll move to CDC?
This is Ann Rhodes from Virginia. I'm the HIV Surveillance Director.
Great. Thanks, Ann. Okay, and from the CDC team?
Hi, this is Kathleen Green. I'm a behavioral scientist and one of the co-leads of the Data to Care work group.
Hi, this is Luke Schaus. I'm a medical officer, and I'm one of the co-leads of the Data to Care activity.
Great, thanks. Whoops, I think somebody's phone might be ringing, or a call line. And from the JSI team, just really briefly.
This is Jeremy Holman, the project director.
Jean Day, one of the technical specialists working with Colorado and Maine.
Hi, this is Julie Powers. I'm a TA specialist working with Hawaii and Florida, and I'm in our Atlanta office.
Karen Schneider, I'm a TA specialist working with Virginia, South Carolina, Massachusetts, and I'm in the Boston office.
Molly Higgins-Biddle, I'm a TA advisor on the project.
And this is Amy Flynn. I am the project support for the Data to Care project.
Great, and we'll turn it over to you even a moment. Just a quick summary of our plan today. We'll have about a 25-minute presentation from Eve. Some of you may have received slides. If not, we'll be sending those to the others of you for reference, followed by a Q&A discussion. Please hold your questions until that time, and again, if you could mute your lines until that time, that would be really great for the quality of the recording. Before I turn it over to Eve, any general questions before we get started? Okay, great. Thank you all for joining. Really looking forward to an informative webinar and a very lively discussion afterwards. And Eve, we'll turn it over to you now.
Thank you, Michelle. Good afternoon or morning for those of you out west. Today I have the pleasure of presenting considerations for developing data sharing agreements for your health department Data to Care program. Let's see, I thought that slide was, just a minute. There we go. The learning objectives are: understand the decision process for sharing personally identifiable information on persons living with HIV with agencies outside of the health department, review the 10 guiding principles for data collection, storage, sharing, and use to ensure security and confidentiality, and understand how to apply them to the decision-making process. And 3, identify and discuss the essential elements to include in a data sharing agreement. We've included a slide at the end with references and URLs so you can look in more detail at any of the documents that I will be referencing today. Let me start with some acronyms and definitions. MOU, MOA are Memos of Understanding and Memos of Agreement. DUA, DSA, Data Use and Data Sharing Agreement. S&C, Security and Confidentiality. Data to Care, or DTC, is the abbreviation I'm going to use today to mean data to care, which is our overarching term for using surveillance data to identify, locate, link, and or re-engage persons already diagnosed with HIV into adequate medical care. If linkage is being done based on, for example, finding a person living with HIV previously diagnosed by a provider whose identity is not based on surveillance data, that is similar to but outside of the scope of data to care. ASO, CBO, or AIDS service organization, or community-based organizations. Usually an ASO provides direct services to clients, while a CBO may or may not provide services. Since the names mean different things to different people, for simplicity today, I will use the term ASO during this presentation to mean either an ASO or a CBO. Data. This word often means aggregate information, for example, a table where one is concerned about small cell size, potentially identifying an individual. But for data to care, we mean individual level, personally identifiable information, as defined in the next slide. Last of the acronyms, but perhaps most importantly, is personally identifiable information, or PII. It is defined as data that can be used to identify, locate, or contact individuals or establishments, or reveal the characteristics or other details about them, and any other information that is linked or linkable to an individual. There are both direct and indirect identifiers. Direct identifiers include name, social security number, or other information that is unique to an individual. Indirect identifiers include uncommon race, ethnicity, extreme age, unusual occupation, and other details, especially in combination with each other or other information. I refer you to the S&C guidelines, which are at the bottom of the slide and listed on the reference slide at the end for more examples of PII. I'd like to review the questions I'll be answering in today's webinar. How is data sharing defined and used in HIV prevention and care? What principles underlie data sharing? What questions should our health department ask to prepare to share data? Who are our sharing partners and considerations for sharing? What type of DSA should we use and how do we share the data? What are the S&C issues involved with data sharing? What are the essential elements in a DSA? And what sample DSAs are available and what sources should we reference for this process? Okay, let's get started with how data sharing is defined and used in HIV surveillance, prevention, and care. Data sharing can be defined as allowing minimum access to PII to public health staff or agencies outside of the surveillance unit for specific public health purposes. More information on this definition can be found in the source document at the bottom of the slide. The bullets cover several reasons for data sharing: partner or contact management, integrated assessment of parallel epidemics or syndemics such as TB, hepatitis, and STIs, quality of care assurance, limited public health research purposes, and engagement with care and treatment assurance. While this final bullet is most relevant for data to care, I think it's important to include all of these reasons for data sharing because it puts data to care activities in the context of other reasons we share data in HIV surveillance, prevention, and care. Engagement with care and treatment is relevant to data to care because in order to engage persons living with HIV into care and treatment, we need to share their name, locating, and other identifying information. A data sharing agreement is defined in the 2011 S&C guidelines as a mechanism by which a data requester and data provider can define the terms of data access that can be granted to requesters. Today, I will use the term DSA broadly and later go over types of DSAs and the essential elements to be included. But first, I will start with the decision-making process, which itself starts with the 10 guiding principles for data collection, storage, sharing, and use to ensure security and confidentiality. Moving on to these principles that underlie data sharing, I'm referencing the article by Lee and Gostin, Ethical Collection, Storage, and Use of Public Health Data, a proposal for national privacy protection, because it is the basis for the 10 underlying principles contained in the 2011 SNC guidelines, and to share this quote. The authors start by saying, despite its critical importance, there is no national standard for safeguarding data held by public health agencies. Instead, privacy safeguards are fragmented across 50 states, creating uncertain and inconsistent privacy protection. I include this quote because I think it helps us see that we're charting new waters here and explains in part why something so basic to public health work has seemed so confusing. Hopefully the technical assistance CDC is providing via JSI, the 2011 SNC guidelines, last year's webinars on the topic, which I will describe more later on, the Data to Care tools on effectiveinterventions.org, the capacity building assistance programs, and other efforts will coalesce into more cohesive standards using the basic principles from this article and listed on the next few slides. That said, while CDC, JSI, and others can provide information and support, some of the decisions must be made at the state and local levels based on local laws and regulations while conferring with legal counsel. In any case, data sharing should be a careful and thoughtful decision and process. The next two slides contain the 10 guiding principles I just referenced previously. I recommend you reference them frequently as you go through the data sharing process. They are, number one, public health data should be acquired, used, disclosed, and stored for legitimate public health purposes. Programs should collect the minimum amount of personally identifiable information necessary to conduct public health activities. Number three, programs should have strong policies to protect the privacy and security of personally identifiable data. Number four, data collection and use policies should reflect respect for the rights of individuals and community groups and minimize undue burden. Number five, programs should have policies and procedures to ensure the quality of any data they collect or use. Number six, programs have the obligation to use and disseminate summary data to relevant stakeholders in a timely manner. Number seven has direct relevance to data to care. Programs should share data for legitimate public health purposes and may establish data use agreements to facilitate sharing in a timely manner. For more discussion on what is a legitimate public health purpose, I refer you to Standard 2.1 in the 2011 SNC guidelines. Briefly stated, however, a legitimate public health purpose includes efforts to prevent disease or premature death or promote health among members of a community through activities, several examples of which are in the guidelines. Different programs may interpret this differently. Continuing on with number 8, public health data should be maintained in a secure environment and transmitted through secure methods. Minimize the number of persons and entities granted access to identifiable data. And number 10, program officials should be active, responsible stewards of public health data. Once you've reviewed the 10 guiding principles, these are questions to prepare you for your data to care activities. Number 1, in order to conduct data to care, will the health department need to share personally identifiable information from surveillance? Number 2, why do we need to share surveillance, PII? What specific data elements will we need to share? Who will we share it with? I will come back to this topic in more detail. What will they do with the data? Do laws or regulations prohibit or limit this sharing? What is the experience handling confidential HIV data of the parties who will be accessing HIV surveillance data? And do they currently meet the 2011 SNC guidelines? The next several slides address the questions: who are my sharing partners, and what are some considerations for sharing? Internal sharing, that is within the health department but across bureau, divisions, centers, etc., is guided first by public health need. This is guiding principle numero uno, and then by compliance on the part of all parties with the 2011 S&C guidelines. CSTE, the State and Council of State and Territorial Epidemiologists, held 5 S&C training webinars last year, and technical assistance for them is available by viewing the 2013 webinars and tools and examples found in the webinar library at cste.org. Internal sharing usually uses less formal agreements than sharing externally, that is outside of the health department. But putting sharing agreements on paper, regardless of what it is called, even for internal sharing, is a great way to make it clear what can and cannot be done with the data. This is important because HIV surveillance usually has a different idea of how to handle the data. Although as stated in this slide, all parties should be trained in the S&C guidelines before sharing occurs, putting it in writing reinforces those guidelines and the training and helps mold the culture of all parties so they're in compliance. External sharing, back to my last bullet here, that is outside of the health department, is more challenging and is the focus of today's webinar. Who are the external partners I will share with? You can share with valid data to care partners, and primary examples include healthcare providers and ASOs that are acting on behalf of the health department. They have been given, quote, public health authority. On the next few slides, I will focus on ASOs because sharing with them is a newer idea with more complex security and confidentiality issues. An ASO as a data to care partner is defined as one that is acting on behalf of the health department and has been given public health authority via a contract, data sharing agreement, or other legally binding document. Usually such an agency diagnoses and or treats HIV infection and has a relationship with the health department, but just being, for example, a health department funded testing agency isn't sufficient to share surveillance data. You want to spell out the details in a legally binding document that could include, for example, the names of the specific staff who have access to the data, what data elements will be shared, and should include what they can and can't do with the PII being shared. You may want to address liability issues for violation of the agreement. We'll go over this when I discuss the essential elements of a data sharing agreement. This slide is an overview of considerations for sharing surveillance data with ASOs that do not already have the patient's name. This type of sharing with ASOs for data to care is dependent on establishing their authority to act as an agent of the health department. It should only be done with careful consideration and planning. Release from the person living with HIV is probably not required since the ASO will be given public health authority, but it could be beneficial and should be considered. Their role is likely limited. If determined that there is a role, a data sharing agreement of some kind is required. Oversight with initial and ongoing S&C training will be integral to successful sharing, which I will discuss in more detail later. IRB review may potentially be helpful, and currently there are no clear examples to draw on. What are some considerations for sharing new information on specific cases? If new information on a person living with HIV is going from an external agency to the health department, no data sharing agreement is needed between the health department and the external agency. Information going from an external agency to a health department for a public health purpose is exempt from HIPAA and can be done without a DSA. If the agency insists on a DSA for this sharing, it must spell out clearly that the DSA covers the information being shared for data to care only and states explicitly that the DSA does not cover information shared to report a case of HIV infection to the health department. Without that, it starts us down the proverbial slippery slope of needing a DSA for an agency to report a communicable disease, something that could inhibit reporting and is not part of standard reporting practice. The second bullet covers when new information on a patient is going from the health department to the external agency. In this case, a DSA is needed. If the names originated from the health department and are going from the health department to an external agency and being re-released To others, such as a provider network, I recommend that you consider a DSA among all 3 agencies. I will provide an example of this type of DSA at the end of the presentation from the New York State Immunization Registry, and is for groups of organizations who plan to share PII. Now I will review types of DSAs and how to actually share the data itself. The legal meaning of the terms in the title of this slide seems to vary by organization. Some common meanings for health departments include MOU is a statement of principle, that is, an understanding. An MOA would specify services and or what is being shared. A DUA or DSA could include or be an attachment to MOUs or MOAs, or used more generally to describe any document that is used as the basis of sharing PII with an agency external to the health department. There seems to be a lot of variety in what these terms mean and when they are used. One health department I spoke with used MOUs only for sharing specimens for incident surveillance. Even the notion that a DSA is for agencies external to the health department varies. Another health department I talked with used them for sharing across organizational boundaries within the health department. I think most health departments do not use formal DSAs internally, but it's always a good idea to put terms of data sharing into writing, even internally. A good place to start is to look within the health department for other models of data sharing and agreements. This may give you a good sense of what the norm is for your jurisdiction. MOU, MOA, DUA, DSA, what should we use? The takeaway message here is not to get hung up on what it's called. Which specific template to use will be determined by the legal counsel of the organization providing the data, that is the PII. The organization providing the data is usually the health department, but secondary release could specify another agency. What I mean by secondary release is if the health department shares data with an external agency, for example an ASO, and then that ASO wants to share it with others, for example providers. If so, the original DSA should either specifically allow or disallow secondary release, and if allowed, the terms of such release should be spelled out. This needs to be a deliberate process with thorough discussion between organizations about why and how PI is to be shared. What is more important is that the essential elements to be included are contained in whatever agreement you write. However, legal counsel may add or subtract from the essential elements I'll be going over in a bit. Once it has been determined that you will be sharing the data, how may PII be shared? Data may be shared using secure electronic methods, for example, using an encrypted file or SFTP in accordance with S&C Guidelines Standard Number 5.0. Over the phone is an option, as is direct contact with surveillance units. For the second and third bullets, health departments should be guided by how they use these methods of sharing information during routine case reporting activities. How may PII data not be shared? Using paper should be discouraged. It is harder to control access and too easy to leave somewhere. Never ever an email, even inside the health department. See Standard 5.3 in the 2011 S&C Guidelines. Even though this standard says emailing unencrypted PII is not allowed, implying that encrypted is allowed, the content of email can be subject to Freedom of Information Act requests, FOIs, which implies that the health department may need to unencrypt it to respond to such a request. This is my rule of thumb for sending any email, but especially email to, from, or within a government organization. Before you hit send, picture the content in letters 3 feet tall on a billboard on the highway. I actually find this quite helpful. Does it still look okay? You can hit send. If it doesn't look okay, don't send it. What guides the security and confidentiality of data sharing? State laws and regulations related to bidirectional sharing or individual-level HIV case surveillance data, and internal and external agency compliance by the providing and receiving agencies with the S&C guidelines from CDC. State law. All data sharing work starts and ends with legal counsel review. You should understand requirements of state reporting laws and rules and regulations. Legal counsel will determine the need for an MOU, MOA, or DSA. IRB review can include a DUA. This will probably not be needed for linkage to care activities, but it's better to have at least discussed it beforehand. The 2011 S&C Guidelines. The subtitle of this document is Standards to Facilitate Sharing and Use of Surveillance Data for Public Health Action. The core principle, value, understanding of the standards listed in these guidelines is that both the health department and any organization with whom a health department shares PII must comply with them. Remembering the minimums I emphasized when I was reviewing the 10 principles earlier. Minimum data elements shared and stored, and minimize the number of people who have access to the PII. This means that the health department's first step in developing a data to care program is compliance with the S&C guidelines. CSTE produced a series of webinars last year on how to comply and included one specifically on data sharing on July 25th, 2013. It includes presentations from New York City and Louisiana, and the reference and link to it is included in the reference slide below. Security and confidentiality is our highest priority. Even after a formal agreement has been executed, S&C guideline training should be done upon hire with all new employees and annually. Training is an ongoing process and can involve changing the culture of a program or agency. The content should reference stipulations in either informal or formal data sharing agreements about what can and cannot be done with the data being shared. That way the training reinforces what's in the agreement. S&C training is an ongoing process, and the policies and procedures should model a culture of maintaining the highest level of confidentiality for PII. The health department can assist external agencies with practices to promote this. For example, placement of confidential fax machines and copiers. Training can be in person, which works well when done periodically, or, for example, staff can sign off after reviewing a series of slides or a policy. There's an example of this from Kentucky Public Health in the August 26, 2013 webinar in the CST webinar library. I will start to close by reviewing the essential elements of data sharing agreements. Once determination is made that a data sharing agreement is needed, the following elements should be included. Specific identification of the parties providing the data, receiving data, and all of those who will have access. Purpose of the agreement. What public health goal is being met? Include authority under which sharing is being done for both parties. Rules and laws may be different for the two parties. For example, does HIPAA apply to the health department and or the external agency? Rules and responsibilities of all persons with access to the data, and this includes a description of staff training and confidentiality certifications, and can and should specify adherence to the guidelines. Description of data to be shared, such as specific data elements and data formats. In this area, clear, unambiguous language is especially critical. It should include allowable and unallowable uses, and consider including any unallowable uses that are of particular concern. Include whether the information being shared can be redisclosed by the receiving party. Data ownership. Does the health department retain ownership? This is most important when the applicable laws of the health department persist in governing the uses and disclosure of the data, regardless of who holds the data. And the methods data will be shared, that is, how often and how transmitted. This is my last slide on essential elements. The date range should also be included. That the date range data that are the date range data that the sharing agreement is in force, and the renewal termination date, including procedures for rescinding the agreement. Specific physical and electronic data security procedures. Procedures to destroy or remove access to data at the termination of the DSA agreement, the process for amendments and or addendums, notification of breach or misuse of data, and penalties for noncompliance or violation of agreement terms, and lastly, signatures of the certifying officials. So the DSA is done. What do we do now? Well, you share the data, monitor compliance, ensure initial and ongoing S&C training, amend the DSA as needed, renew the DSA or close it out. Frequency of that for renewal will likely be determined by legal counsel, but annually would be a good frequency to consider. This slide includes a list of sample DSAs in no particular order, and to maximize our discussion time, I'm not going to review them right now. JSI is providing these slides and sample DSAs to you for your review. This is a list of references for you to use when doing this work. I will quickly show you two that I think will be primary references for you. These are the 2011 cross-program integrated S&C guidelines from CDC. They represent the first time CDC produced guidelines across all of the divisions in the National Center for HIV, Hepatitis, STD, and TB prevention, and are the basis on which data sharing is done both within and outside of the health department. You should familiarize yourself with this document, and the health department should review their own compliance with it before considering data sharing within or outside of the health department. This is the Interjurisdictional Health Information Exchange Guidance for Public Health Agencies, published in September of last year by the Joint Public Health Informatics Task Force. I'm including a picture of it here because you may not have seen it before. It is very practical and I think can help guide your work. It's geared towards health departments from neighboring states sharing data with each other, for example, sharing information in immunization registries, but has much information relevant to the kind of sharing involved with data to care. Before opening up for discussion, I want to close by thanking Luke Schaus, Pat Sweeney, and Mark Stenger from CDC and the JSI staff and TA providers for their helpful input and comments. Amy, you want to take it out, or Michelle, for questions and discussion?
Yeah, great. Thank you very much, Eve. So now we're going to open it up to any questions or discussion. We really see this as an opportunity for cross-health department learning. And we have Eve as well as CDC as resources and the JSI TA specialists on the line, but we're really happy to have Eve here to provide some, facilitate the discussion and provide some consultation. So if you can open up your line and ask your question, please state your health department and, again, your name and role within the health department. That will help.
I want to make sure that I address the kinds of questions I know that specifically Colorado and Virginia had. And I found in order to keep this to a half hour, I had to not necessarily address every single thing you asked about. So please do bring up, this is the time for this, bring up questions you might have had that I didn't address. Just anything that's come up for you around this whole issue of how the heck to share data in a confidential way, because we are charting new waters here, and I think we can learn a lot from talking to each other. Are there details or questions that I'm sure I didn't touch on today that you had that you wanted to get answered?
Eve, this is Ann Rhodes from Virginia. I'm the surveillance coordinator. So I know, one of the things that I know our prevention and care people couldn't be here because they've actually got a couple of their meetings today. So I'm sort of speaking, or the coordinators couldn't be here. So I just want to. One of the issues we've been sort of struggling with a little bit, I think, as we've talked through this is, so we've got our loss to care list that we've generated from, we've matched our care and surveillance data together, and then, we sort of have limited DIS ability to go out and work with people. We're funding a lot of patient navigation throughout the state, so we'd really like to be able to use patient navigators, I think, and to do some of this loss to care work. And what we're trying to determine is, can we give these loss to care lists to patient navigators at these different sites? Some of them are medical sites, some of them are CBOs. And so I think that's where, I think the information you presented is useful as far as sharing the data. I think we're still just trying to figure out, is there any sort of, limit on what we share with them, as far as, can we share, all of our HIV cases, because, going back, we've got all of them, all our living HIV cases that we know have fallen out of care. And so is there any kind of limit on what we share for people to go out and try to find people?
Where did you say they worked? You said CBOs, and where else? I kind of missed that.
Medical sites, so medical provider sites.
Uh-huh. I mean, I think some of the things I touched on really help, and I think I have to thank Pat Sweeney for suggesting I put circles around the words minimize and minimum in the 10 guiding principles, and I think that partly answers some of your question. I mean, you want to ask yourself, what's the minimum amount of information I need to give them? I would not open up your HIV registry for them to be able to look up anybody they want. I'm not saying you're suggesting that, but that would be the other end of the extreme, completely unnecessary. You've worked on it, you know, I know you weren't suggesting that, but it's a good extreme to think about on the other end. If you developed a not in care list and they have particular, you know, you've made a decision about why some of them would be best to follow up on particular types of patients, I think you have to do all the training with their organizations. If they work for lots of different organizations, that's going to be more challenging, I think. Because of the training that you'll have to do with the different agencies that you would have to have a data sharing agreement with in order to do it. I would also suggest if you haven't tested out your not in care list, you're probably aware that a lot of people found, you know, when people start doing this work, they discover things like, oh, these patients a lot of them have moved, or oops, that time we forgot to do the death match, some of them have died. So whatever you do, I would start with a few patients and see what happens. I wouldn't. So again, I think just keep thinking about the 10 guiding principles, the whole issue of minimum, and again, you'll have to go through the process with the different organizations they work with, so that they are in adherence with the guidelines. Does that help you?
It does. Yeah, I think that's, you know, what we're trying to figure out is what is, you know, what are the kind of the minimum pieces we're doing, and we are trying to start small. We're doing a small pilot with DIS right now in like 3 districts that we're just starting so we can figure out, because I think that is what we've heard is, you know, other states are finding people on these not in care lists who are actually in care. So we do want to see what we actually find as we generate these lists and what the issues are before we would expand it out to a wider audience. And we just procured Accurate and LexisNexis. So we're hopefully going to be able to start using that a little bit to whittle down, or at least figure out some people who might be out of state.
I mean, and you're in a classic situation, like you, Maryland, and D.C. have this classic situation of a metropolitan area that spans 3 jurisdictions. And so, I mean, I'm sure you deal with that all the time with people going in and out of your jurisdictions with Maryland and D.C. on that side of your state anyway. So, yeah, I think that's the approach to take, but I do think you have to figure out how you're going to do the training that needs to take place before you can even share a small number of elements on a small number of people.
Yeah, I think so too. And I think the thing you shared on the interjurisdictional health information exchange will be useful, because we've actually been working to set up a data sharing agreement with DC, which has just been a little bit stuck in administration on both sides, I think, for a little bit. But
yeah,
I'll look through that.
Great, good.
Thanks.
Sure.
Hi, this is Bob Bongiovanni. I'm the Care and Treatment Manager in the state of Colorado. Hello, everybody. So there's a couple of questions that we've been wrestling with. I know a lot of this is actually governed by state law, so we don't expect you to be an expert on our state law. But I'm trying to get my head around this whole idea of secondary sharing. So let me paint a scenario, and you tell me whether we have well, you're going to have an isolated thunderstorm soon, I see.
I closed Weather Channel app, so you see all the city behind you.
I usually say tornado warning. You know,
depending on where my friends and family are at the moment, that's what city gets added to my list. I did close it, but I see it didn't prevent that. Okay, go ahead. I'm sorry.
That's all right.
Very scary. You know what?
Secondary sharing thing.
I'm going to go back to that slide while you're talking.
Okay.
Go ahead.
So let me give you a scenario, all right? So we have a local, so in Colorado, our state health department is a legally separate entity from our local health department. I know that's not true everywhere, but they're complete separate legal entities. Covered somewhat the same under state law, but with some restrictions. We currently fund one of those local health departments to do linkage to care for people in their jurisdiction. We send that local health department a list of people that we believe are, in their jurisdiction that are not linked to care. They take that list and they see, 6 of these clients are eligible for Medicaid and 2 of them are eligible for a Marketplace plan. When they meet with them, they say, here's a list of possible providers you might want to do. We can help you enroll and get that all set up. And the client off that long list picks Dr. Jones. Are you saying that because we told our local health department partner that this client was HIV positive, that our state health department has to have a data sharing agreement with Dr. Jones?
You're referring the patient to Dr. Jones. The patient is taking themselves to Dr. Jones. So you don't need a data sharing agreement with Dr. Jones because the patient is revealing their own status by going to the doctor.
That's what I was hoping you were going to say. But it did originate with a public health record. So there's that, so that local health department would never have known that person was positive and never would have known to refer them to Dr. Jones if it hadn't been for the data sharing at the beginning.
Right.
But I think they didn't reveal, let me give it a second example. We give them the most recent viral load for that client, right, which is 3 years old or something. And then that our local health department partner says, Dr. Jones, we're sending a patient over there. Here's their last known viral load score. That would go beyond.
Well, again, I think if the patient is volunteering that information,
No, they didn't volunteer that information. So we took that out of their public health record. Viral loads are legally reportable. So we not only, let's say we, and we're not doing this right now, but let's say we not only told our local health department partner, we haven't seen any evidence of care for a year, and here's their most recent viral load score from their public health record. Then our local health department partner found out the client wants to go see Dr. Jones, and to prepare Dr. Jones for that visit, said, we sent that patient over to you. We also happen to know that patient's most recent viral load score, and here it is.
This is a situation where having the patient sign off on you sharing that information could be helpful. Luke, do you want to jump in here?
Sure. So, hey, it's Luke Schaus from CDC. I think Eve is exactly right here, that once public health has gone out, contacted the patient is agreeing to then enroll in care with Dr. Jones. I think it's okay for you to share that information with Dr. Jones at that point, because the patient has given their consent for you to set up their care with Dr. Jones. I do think that, having some kind of formal process where you say, we would like to share the data that we have on you with Dr. Jones, which will, help facilitate your care with him, and having them either verbally agree to that and you document that, or having them sign, something that says that it's fine for you to share that information with Dr. Jones. I think that's even more important if it's the first time they're going to see Dr. Jones. If you're re-engaging them in care with Dr. Jones, I don't think that's so important, because it's clear that they already have a relationship with that provider, and that provider should already have a lot of their personal identifying information already. But I think if you are setting that up, I think it would be prudent for the health department to make the patient aware of that and somehow document it, whether it's in, we made the patient aware, they gave us verbal consent, and the DIS or whoever's doing the contact notes that, or you actually have them sign off on some kind of form that says, that as part of helping facilitate this linkage to care, that you're going to share the information you have on them with Dr. Jones. I think that's fine.
These are big changes for us. We have traditionally said that even the clients themselves can't consent to the release of their public health record, right? So we are kind of evolving to this new way of looking at the world.
Yeah. And maybe these are big changes for health departments. They're big changes for the way the health departments interacted with providers, and it's a big change for how we've interacted with HIV positive clients in many areas. So, Eve mentioned earlier with Virginia, which is start small. So maybe you start off by not doing anything other than linking the patient to care, helping them with an appointment, getting them enrolled into that, and facilitating that linkage. And then maybe you move, after that's working for you, maybe you move to sharing, like say, just simple contact type of information and that kind of thing. And then if that's working for you and things are going well, then maybe you move and share a little bit more. I mean, these are big changes, and I think you need to find kind of that the place where you, the health department, when I say you, I mean the health department feels comfortable in moving forward. So, taking everything you have on that patient and printing it out and giving it to the provider, there's nothing that says you need to do that.
No, and that probably wouldn't be even all that helpful. Even in the example I gave, I don't know why a 2-year-old viral load would be particularly helpful to any doctor. The other, let me give you a second case scenario, and this one is actually something we are immediately wrestling with, which might again be a peculiarity of Colorado's laws, but nonetheless, the way we have historically interpreted our law is that our local health partners are entitled to the public health records having to do with people in their jurisdiction, right? So if it's a Denver County resident, we will allow them access to the content of a public health record having to do with a Denver County resident. That's limited just to our local health department partners, right? As soon as we start getting into linkage to care, it gets so interesting now, right? So suppose we have a patient who was tested 10 years ago in Denver County. They now joined our AIDS Drug Assistance Program, and the latest application they gave us shows that they no longer live in Denver County. We find out they're not being linked to care properly, so we send somebody out to go talk to them, and we find out they moved to a third jurisdiction, right? They're now sleeping on a couch in Adams County. Who of all of these counties is entitled to that public health record? Now that client has a reason to be sort of linked with 3 different jurisdictions, and we are really wrestling with, clients do not suddenly go, oh, I'm crossing a county line. I now have a different kind of legal protection over my health information. Now it's only going to go to this new person I'm sleeping on the couch with for 2 days, right?
Let me tell you my perspective on that. And I'd be curious to hear Luke, but I want to jump in first before I let Luke respond. I think the answer to that question is yes, all 3 of them, and I'll tell you why. You have to think about where the responsibility lies for public health action. And any local health department has the responsibility of protecting the health of the people in their jurisdiction. You cannot possibly know at what point in time this person is in what local health department's jurisdiction. If there's a reason, if they've been in that jurisdiction or you think they're there now, there's a reason for it, and you're mistaken and you find out it was supposed, they've moved to County Y. I don't think you can possibly keep track of that. I think that if you are releasing for a legitimate public health purpose, getting back to our principles constantly, that you have a legal, it sounds like in Michigan we would have, I'm assuming you do as well, they had residents at some point in time in that county, and you had reason to believe at the time you shared with that county that the person was residing there or the provider was there, that there was some public health purpose in that county. I think that's okay. You don't want to overshare, but I really think that's okay. I'm curious what other people think, but that's my perspective. Does that make sense to you?
Oh, yeah. No, well, that's certainly one of the positions that's been taken, but there's other people that are less comfortable with that.
So this is Luke, and I'll give my perspective, and I guess first and foremost I should say I think this is a great example in her presentation. Eve pointed out that a lot of these decisions, she shared a lot of principles and a lot of questions and things to consider, but when it boils down to it, a lot of these questions do have to be answered at the state and or local level, and I think this is a perfect example of that. And in my experience working with surveillance programs across the country, this has been decided different ways. So some health jurisdictions have decided that it's only the jurisdiction where the person currently resides, and that's using the best information that you have on their last known residence. That's the only jurisdiction that has the right to see that information currently. Other areas So like California is an example of where they have allowed, like their surveillance record, if the person has lived in or ever received care in a jurisdiction, then that jurisdiction has the right to see if they either all or part of the record, depending on what has happened in that, what that person did in that jurisdiction, whether they resided there or whether they just received care there. So they kind of split it up, and so some people can see the entire record. Other jurisdictions can only see the part of the record that applies directly to the care that they've received in their jurisdiction. And so they've they've done a mix of that. And then there are other jurisdictions that are just like, the person's lived in your jurisdiction, you provided them care, and you have a right to see the record of that individual, which is kind of what I think Eve was suggesting. And so I think there are examples across the country of all three of those models, and I think what it boils down to is what does Colorado law require? What is its, does it limit it or does it leave it open? If it leaves it open, who gets to determine? Is it the health department who gets to make the decision who gets to see it? And if so, then I think it's up to the health department to ask those tough questions and then come up with what you feel is the best approach, which would have the best, public health outcome.
And constantly ask yourself those questions and those guiding principles. Why am I sharing it? What's the reason? What's the minimum amount of information I have to share to reach the goal or the outcome I'm looking for, et cetera?
Exactly, because if the person was diagnosed 10 years ago in County A, they haven't lived there since. They're living in a county all the way across the state now. Does County A really? Do they have a vested public health interest here to see that data if they're not going to be providing care or not be the entity who could go out and offer linkage services to them? So for data to care, even though they were diagnosed there, it's been long enough, the person's not lived there in a long time, that there's really not a public health purpose for them to really have access to that data at this point.
And really, it's data to care that's brought this to the surface, because historically that's exactly how we've interpreted it.
Yeah.
No matter how long ago it was, once a Denver case, always a Denver case, right? And
yeah.
only a Denver case. And that now data to care is like, well, once we're doing now that we're having a different purpose for this data, that really doesn't make much sense anymore. It really doesn't. And I'm not sure, frankly, I'm not a surveillance person, never have been a surveillance person, but I'm not sure how helpful that was, period.
Yeah.
Frankly, even back when, it's deceiving to see all of that, thinking, wow, this county has a big burden of disease, when in fact, all that was where they were tested 10 years ago, and they just happened to have the best STD clinic out there, or they just happened to test a lot of people during that time, but there's no sense that that's an accurate description of the disease burden of that county. So, getting new updated addresses is a big priority here now.
Some of this is an artifact, and I'll throw this in because you stated explicitly your background wasn't surveillance. This is an artifact from the fact that for 30 years, residence at diagnosis has been how they've assigned morbidity in surveillance. And we're still struggling, because we can't follow people everywhere they go, with being able to switch to current residence. Because residence at diagnosis may have meant something in 1989. It means very little now. And that's the remnant of, Denver, where they're diagnosed, so Denver always gets to know. So I think we have to shift, as we're struggling with trying to have people, maintain most current residence, or whatever you want to call it. But it's an artifact of the ancient way surveillance morbidity's been assigned.
And a day when chances are the person was not going to be living much longer. So
exactly.
It was really a 2-year time frame here, and they probably weren't going to be moving around a lot. But now we have, thankfully, people living decades now, and I certainly don't live in the same county I lived 20 years ago. So why do we expect our clients are?
So this is Luke again, and I just wanted to take an opportunity to jump in because there's the question about, which I think Eve answered perfectly, about the data re-release. And in her slide presentation, she talked about if surveillance shares data with one agency and then that agency is going to re-release it, that you might consider a data agreement that encompassed all three agencies. And although the question I think Denver had, I think Eve answered exactly correct. That's probably not necessary in that situation because the client's giving their consent to be linked to that provider and to share that data. However, what we were thinking about there is an example that some people have brought up to us where some ASOs or CBOs have been in conversations with medical care providers to offer them linkage services for their clients. And so what that looks like would be is a medical clinic would contract with an ASO that when their patients fell out of care, that the ASO would actually be the people calling for that healthcare provider and then going out and trying to get that person relinked to care. That was an example of a situation where we thought, well, if the health department took data to that healthcare provider and said, hey, we see this patient that you used to have, they're no longer linked to care, and if you have linkage services, would you get them linked back into care? And the healthcare provider says, sure, I'll contract with the ASO down the street to do that activity. Then the healthcare provider would then be turning around and re-releasing that information to the ASO. In those that was an example of a situation where we thought that a case that was generated from a data to care activity looking at surveillance data and identifying someone as not linked to care would go to a healthcare provider, and then that healthcare provider may actually be releasing that data to someone who is not actually their employee but may be a part of a program they have for linkage. And so we thought, just to cover the ground and make sure everybody is understanding what's happening and who has access to data and everything like that, it would be good to consider a data sharing agreement that involved all three parties. And that was an example of that.
That helps me understand what you had in mind much better. Thank you.
Mm-hmm.
We have a few minutes left. Any other questions? If you think of something afterwards, don't hesitate to go to your JSI TA provider, and of course they'll contact me if need be, or if you want access to me afterwards, we can see if that can be arranged.
Yeah. Thank you, Eve, and I do want to reiterate that, this is Michelle from JSI, that please follow up with your JSI TA specialist if you would like any follow-up consultation with Eve related to the issues that were raised today. Because this is such an important issue and new arena. So any final questions or comments before we close out? Okay. I do want to say that the TA specialist will be sending a link to the Evaluate this webinar, and we really look forward to your feedback so we can continue to provide quality technical assistance services in the future. So thank you for your feedback, and thank you all for your participation and comments and discussion today.
Thank you.
Thank you, Eve.
Thank you.
Bye now.
Bye. Bye, everyone.